Hello, everyone. Welcome to the show. I'm your host, Ernie De Los Santos, founder and faculty chair at Appeal Academy, creator of Top Gun Audit School. And we are live on the April 15th, 2016 edition of Finally Friday. And I do want to thank you for choosing to spend your time with us here on Finally Friday, because that's your most precious resource. Today's Finally Friday broadcast is sponsored by the Health Law Partners, providing solid advice and real solutions for healthcare business nationwide. One of our partner firms is Recovery Analytics. That's Sharon Easterling's company. She does auditing and education, often authors articles for AHIMA as an AHIMA fellow, and she is a co-host on our show. Finally Friday is now also sponsored by MedLinks Cost Containment, makers of the Healthcare Audit Tracker. Visit zerodenials.com today to see how they can help you track audits and greatly reduce or even eliminate denials. And our newest sponsor is MAS Coding Solutions, a leading healthcare consulting firm with over 25 years in the medical coding industry. They have core competencies in medical coding solutions and medical coding education. And as a matter of fact, today there is a conference going on sponsored by MAS Coding Solutions, the ICD-10 Coding Connection Conference. That's happening in Charlotte, South Carolina. I'm sorry. Now I can't remember whether it's North or South Carolina. Anyway, it's in Charlotte, and that's where, as a matter of fact, that's where Sharon is today, so she couldn't join us on the show. We are also sponsored or partnered with the Council for Certification of Medical Auditors, the CCMA, creators of the widely used Certified Medical Audit Specialist, or CMAS, certification. And we're very proud to have been approved to offer CEUs for all our shows for CMAS certifications. Today, we are very happy to have, and this is what you can get the certificate for CEOs on our website each week. It's on the page for each show each week. Okay, so today, we're happy to have our special guest here to talk about the key things a hospital needs to know about the long-awaited final rule for reporting and returning overpayments to Medicare. I know all of you are very excited about that. Our guest is Jessica Gustafson, one of the founding partners at the Health Law Partners, an award-winning law firm specializing in healthcare law. Jessica recently had an article published by the American Bar Association, and the link to that article is in the slides for today. Jessica graciously offered to do a review of the final rule today so that our audience can freely learn what's going on and what you need to watch out for as a result of this rule. This week, my co-hosts are off doing what they do in their businesses, so they can't join us today, but such is life. Anyway, thanks to all of you for joining me and Jessica today. Now, before we get going, I do want to make clear that the opinions shared on this show are those of the panelists and not necessarily representative of their employers. My opinions are also my own and no one else's, and especially not those of our sponsors. Okay, before we get started, let me switch over to the website because there may be some new people on the call who have not been with us before. So I want to show you, if you are new to the show and you want to know how to use that control panel with the green buttons at the top of your screen while you're in our room, and what you want to do is go to the website, appealacademy.com, and scroll down on the right of any page on the site. You'll get to see this thing where you get meeting room instructions. When you click on that, it takes you to this page which shows you how to, so that in the future there are two ways for you to get the audio, either by using your phone, gives you several numbers, or by using the internet itself. That one requires a little download. That's why we usually recommend you use the phone for hospitals. There is a chat box, which I highly recommend you open and watch, because there's often a separate discussion going on in the chat box. It's an active chat box room. I do want to remind everybody that this is a public chat room. Please keep your comments professional, and remember that we have all kinds of people in here, physicians, nurses, case managers, all kinds of people are watching the show, so please be professional. I want to remind you that while the show is recorded, that chat box is not recorded. There's no record of anything that goes on in there, so it's not discoverable. And when I mention things in the show about things that people write in their comments or questions, I don't normally mention names, unless it's somebody that I know and they're okay with it. There is a way for you to zoom in on the screen if I'm not zoomed in enough on something for you. Just remember that you have to zoom in and out yourself then. And then there's a list of participants, that second box on the right. You are the one listed at the top on your screen. If you hold your mouse over the U, then it will give you a chance to change that, put in your name or a first name or a nickname or whatever. You don't have to do that if you don't want to. But as you see from the participants box, there are a lot of people who do that, so you can talk to them directly. Okay, let me get rid of that. Oh, and if you're looking for the handouts for the slides, you want to go to This Week on Finally Friday. Each Friday we have this page, and if you scroll down, there's always a Get the Handouts link. If you click on that, it immediately takes you down the screen to where you can get the handouts now. I changed the situation so you don't have to enter emails or anything. They're just direct downloads, and you can see what we're offering for this week. There's also the replay of this week's show. That'll be in there. And by the way, here's the certificate if you're a CMAS holder. And then here is the link to last week's show. And by the way, if you're looking for last week's show, I had the wrong link posted until a little while ago. And I also lost the page of last week's show, so I have to regenerate that and post all of that probably by tomorrow. But here's the link if you're looking for that. Anyway, if you have any questions about that, there's a little box at the bottom of your screen that says Leave Ernie a message, and you can do that on the website at any time. Okay, I think we're through with all that. Let me get back to the slideshow. And there we go. Okay, and so let's talk about what's going on. Last week, we talked about how to make CDI deliver what it promised in the beginning. It's supposed to make documentation better and reduce denials. Well, it's not really doing too well at that. But we talked about it last week about how it may seem impossible, but that just makes it more worth the work of going after it. And we talked about how to do that. And then this coming Monday or Tuesday, this webinar should be up. It's a free webinar. They should be available, like I say, Monday or Tuesday. It's by Sharon. It's where she goes definitely in more depth than she did on that show last week and talks about also the building blocks of documentation. So all that coming up. Watch for the email announcements about that. This week, of course, we are talking about the reporting and returning overpayments final news, final rule. And I do think there's a very slick trick that CMS did that nobody saw coming, and I think Penn and Teller would appreciate it. A couple of news things before we get going. There was an interesting article that I saw this week in Healthcare Finance about how here's one hospital that's saying, wow, we want to do more bundling. We really like that. They saved a lot of money on costs and delivered better care. Let's see, what did they say? They were, cut the percentage of patients receiving rehab care from 74 to less than 25%. I think that's worth looking into and reading about. So you might want to go look at what this guy is saying about that. Of course, that's just in their hospital, and your mileage may vary, but I think that's a very interesting thing. I'm sure CMS is going to pounce on that as the justification for what they're doing, and maybe it's a good idea. The other thing is that MACRA, most of you have seen our shows, or some of you seen our shows about MACRA. That's the new way they're going to be paying for performance. That is growing and just keeps changing, and it looks like it's going to keep changing and changing and changing. Here's an article with a man from AHIMA speaking about it. He's from CMS. He was speaking about it at an AHIMA conference in Washington, D.C., and so there's the article about that. I thought it was pretty interesting how they talk about that. But there's a lot of changes happening between now and 2019. So good to stay up on that. Okay, so this week You know, the trouble with this reporting and returning overpayments rule to me is, you know, this is CMS keeps saying, you know, they're in search of the truth. Well, there's a few problems with, if you just think about for a minute, you know, how can you find the truth? You know, Nietzsche said there are no facts, in other words, no truth, there's only interpretations. I think I kind of agree with that. But you know, what CMS is doing, well, they're saying, you know, we want to find the truth. We want you to basically turn yourself in. So they want you to find the truth and surrender. So here are all the examples I thought of, you know, what about the truth? You know, if you look in the mirror, are you really seeing the truth, or are you seeing what you want to see? You know, there are things that you really should surrender to, like if you're being chased, or if you're at war, and then, of course, there's Jack Nicholson saying, you know, you can't handle the truth anyway. What do you want with it? And then, of course, X-Files. The truth is out there somewhere. The trouble with all of this search for the truth and wanting to surrender to it, is that, you know, here are the kind of results we're getting. They are looking for at CMS. They want to hold us accountable. But what we wind up with is CMS, you know, you call them or you get on their webinars and you ask questions, and they don't really have any answers because there's nobody on the line ever who's got the real answers. So we wind up with these gray areas. And the trouble with gray areas is they don't give you any real answers. So fortunately, though, CMS has been at least paying attention to the fact that there are gray areas that have been looking for answers. So, you know, they went heads down, did all the hard work to go look for it, the answers, and so now after 3 years, 3 years or more of doing that, they finally came up with CMS 6037, the final rule. Here's the link to that. And in that, so basically we come back with 3 key definitions that got clarified. It's no longer gray area. Who is a Medicare contractor? What is an overpayment? And who is a person? I don't know about you, but I really didn't think I needed those clearly defined. But anyway, it's a legal thing, so I guess you do, right, Jessica? You got to have these things defined.
Yeah, I mean, I actually think the irony of it is person they defined as, you know, not a person.
Yeah, okay.
But I'd agree with the other. Sure.
Yeah. So we'll let Jessica get all that in a minute. And then there's one remaining gray area, which is a big gray area, and Jessica's going to talk a lot about that. The idea of reasonable diligence, that you've extended reasonable diligence in going and looking for problems in your billing. And, you know, they have stubbornly really not well defined that, although they give some examples. Jessica will talk about that. And there's one thing that's really scary, like this recent edition of the Boston Globe. This is even more scary, a 6-year look-back period. In other words, you know, how serious are they about that? And are they going to really hold that to you? The RACs can look back 3 years, but you have to look back 6 years? Well, at least they didn't get the 10-year look-back period, which was what was in the proposed rule. Okay, so again, Jessica will go into that. And then there's this one sleight of hand that I already mentioned. Whoops, that's interesting. My PowerPoint just stopped, and it's restarting. Okay, let me get back to that. And here we go. Why was it... no, that's not the right show. Sorry, gang. That was the wrong one. Nothing like live television. All right, let me get, I got to get the right show up because it's not cooperating. Here we go. This is the one I want. Let me get to the slide that I want, where I am in this. And get that back up. Okay, here we go. So the sleight of hand that I mentioned is that CMS figured out how to make you become their statistician for doing extrapolation. They no longer have to go do them. Their contractors don't have to do them. They want you to do it. So we'll talk about that and see. So this is the link to the article that Jessica and Clinton wrote for the Health Law Partners, and it was published in the ABA Health Law section. And that is the basis for the talk today. I've been showing everybody that for the last couple of weeks, so hopefully you've gone and looked at that, or we'll go look at it and learn even more. So now, time for me to shut up, and it's Jessica's turn to educate you instead of whatever it is I do. Okay, Jessica, it's all up to you.
Okay. So can I do the slides, or do you have to do them?
Oh, I have to do them, but yeah, so
Okay.
Here we go.
So here we go. All right. Here's the boring legal stuff. So this all came to play as part of the Affordable Care Act. Section 6402A of the Affordable Care Act changed the Social Security Act to require a person who receives an overpayment to report and return the overpayment by the later of 60 days after the date on which the overpayment was identified or the date any corresponding cost report was due. So failure to do this would subject you to False Claims Act liability. There was a proposed rule. Can you go back one?
Oh, okay, sorry.
That was published in 2012. And then kind of crickets after that. There were over 200 timely submitted comments that CMS received and looked at. There were a couple lawsuits that were tried on this issue, but there wasn't a final rule until this year. So the final rule was published February 12th, 2016, and it was effective on March 14th of 2016. I have the reference to the final rule. I know Ernie's linked it for you. The CFR reference is it's 42 CFR 401.305.
Okay.
Okay.
Next slide.
Okay, so note that this final rule is expressly limited to Medicare Parts A and B, but CMS did go through an entire discussion that, the law applies to all parts of Medicare and Medicaid. There was a final rule related to reporting and returning overpayments for Medicare Parts C and D that has already been published. Although there hasn't been anything published for Medicaid claims, CMS did make a point to remind all stakeholders that even without a final regulation, they're subject to the law. So just keep in mind that even though these regulations are applicable to A and B, your duty extends to all parts of Medicare and Medicaid.
Okay.
Okay, as Ernie said, there were 3 new defined terms that are explicitly noted to be new definitions. And Ernie, I agree with you. These are the least important words in the final rule. But
Yeah.
so Medicare contractor means a Medicare contractor, so that's easy. Overpayment means any overpaid funds that you've received. And then person is defined to include a provider or supplier, but the rule does make a point to say a person is not a beneficiary.
It's like big deal. Like I don't even know why they need to say that, but okay.
Yeah. Okay. So, all right, that's the general rule. We already went through that. A person must report and return an identified overpayment by the later of 60 days after the date on which the overpayment was identified, or the date the corresponding cost report was due. There are 3 scenarios where the 60-day time frame does not apply. Those 3 scenarios are if you receive receipt from the OIG acknowledging that they have received your submission under the OIG self-disclosure protocol. Just, tread lightly here when you're worried about time frames. There's some admissions that go along with that, too. If you're worried about your 60 days, I don't know that you need to necessarily go running forward towards an OIG self-disclosure unless, that's appropriate and your legal counsel agrees that's appropriate. Another exception would be if CMS acknowledges receipt of a submission to CMS Voluntary Self-Referral Disclosure Protocol. That's the STARK Voluntary Disclosure Protocol. Or if you request an extended repayment schedule to return the overpaid funds that you've identified.
Okay, so just to clarify this OIG self-disclosure protocol, that's a completely different How would they
Right.
get into that? How does that happen?
So the way that works is if you have determined that your facility has received, fraudulent claims, then you can enter into this self-disclosure protocol. I think let me give you the exact words that the OIG says. This protocol was created in 1998 to voluntarily disclose self-discovered evidence of potential fraud. So if you're going down that road, you're pretty much acknowledging that your claims were fraudulent. So that may or may not be appropriate. I just, would advise you to make that determination very cautiously.
In other words, they're saying that, okay, well, this sounds like one program stepping on another one. They're saying, okay, if you're doing it that way, we just officially say we're not holding a 60-day time frame over you anymore.
Exactly. If you've already done a payback, it's the whole thing.
Okay. And the same thing with this other
with the
voluntary self-referral. Okay. That's about Stark.
That's about. And then the third one is when you've identified the overpayment, if you think, there's no way that I can pay this back within 60 days, you can request an extended repayment schedule, and then the 60-day time frame would not apply.
Oh, okay. Okay. The 60-day time frame to report and return. Okay. All right. So you've already determined it, and you've decided that, well, this is too much money, I can't pay it back, so I have to do something else. So they then stop counting the 60 days. You're not going to be held liable to that while they negotiate something with you. Okay.
Exactly.
All right. Okay. A person.
Okay. All right. So I think one of the main key terms in this final rule is identified. And this is a term that was part of the previous litigation. It was something all legal counsel were debating back and forth. When have you identified the overpayment? When somebody says you've been overpaid, after you've researched it, how do you possibly know that? So the final rule does make an effort to clarify this and defines the term identified to be when a person has or should have, through the exercise of reasonable diligence, again, we'll go through that term too, determines that the person has received an overpayment and quantify the amount of overpayment. So there's a couple elements in here, and we'll walk through them all in turn.
Okay. So next one is about the reasonable diligence, which I think is the big gray area.
Exactly. So CMS states that you've identified an overpayment when you have, through the exercise of reasonable diligence, identified the overpayment. So reasonable diligence is expected to include both proactive compliance activities to find potential overpayments and reactive investigative activities undertaken in response to receipt of credible information related to a potential overpayment. So credible information, that's also discussed in the final rule. These aren't just words I'm making up here. These are all taken right from the final rule.
Okay. And the big sticker to me when I first looked at this was this idea of the potential overpayment, which I found to be very interesting because, for crying out loud, in today's reimbursement environment, if you send a claim in, it's a potential overpayment.
Well, exactly. Ernie, let's go to the next slide because that kind of touches on it. Proactive compliance activities it's very much just something CMS is expecting your hospital to be conducting as a matter of course. And it's my understanding that most hospital systems do have a fairly robust compliance program in place, which does include some internal auditing. So this may or may not be a big difference to the way that your facility conducts business. But there was some discussion within the final rule by commenters that requested CMS to clarify that there's no duty to go proactively hunting for overpayments when there's no reason for you to expect that there are any. And without really addressing the question, the way CMS responded is they stated that these comments underscore our concern expressed in the proposed rule that some providers and suppliers might avoid performing activities to determine whether or not an overpayment exists. And then they just go on to say, as discussed earlier, the statute requires a person to report and return overpayments. Thus, providers have a clear duty to undertake proactive activities to determine if they have received an overpayment or risk potential liability for retaining such overpayment. So basically, CMS is taking the position that you must be self-auditing as a matter of course, even if you don't have credible information that an overpayment may exist.
But they really sidestep the whole question, really, right? Because they're saying, well, if we say that you don't have to, well, then you might avoid it.
Right.
And so they're saying, well, you have a duty, which is kind of a non-answer answer, isn't it?
Yeah, I mean, it's an answer. It's an answer. It's not a direct answer.
Yeah.
So,
okay.
I mean, I think CMS is saying there is, in fact, a duty to proactively search for overpayments without a reason to believe that a specific overpayment exists.
It's just, it just boggles the mind to think, well, what are we supposed to do? Yeah, well, okay, they don't really clarify. All right. I guess we're stuck with it. It just kind of makes it, though, an issue that can be argued a lot, right? Get to court about this, and they may argue you're not doing enough, and you can argue you're doing enough.
Yes.
Okay, well, all right. Next slide.
Next slide.
We're still about proactive.
Yes. So an interesting part of the final rule, actually, let's take a step back and talk about Section 6401 of the Affordable Care Act. That portion of the Affordable Care Act is the one that required all providers and suppliers to establish a compliance program. So up until the Affordable Care Act, it wasn't the case that all providers were mandated to have a compliance program in place. There was a proposed rule that was issued in 2010, and there's still not a final reg on it. But in the proposed rule, CMS solicited comments as to whether use of the 7 elements of an effective compliance and ethics program set forth in Chapter 8 of the U.S. Federal Sentencing Guidelines should serve as the basis for the core elements of a compliance program. So oftentimes when legal counsel are advising physician groups, other providers and suppliers about the elements of their mandatory compliance program that they should be adopting, everybody goes back to these 7 elements because those are the elements CMS was soliciting comments on. Everyone thinks that's really the way CMS is going. There are these protocols that the OIG has published. These are all things that everyone really understands to be CMS's expectation. But interestingly, in the final rule relating to the one we're talking about right now, reporting and returning Medicare overpayments, CMS considered and affirmatively declined to create a presumption of reasonable diligence if your compliance activities mirror the OIG's compliance program guidance or the U.S. Federal Sentencing Guidelines. So
wait. Go ahead.
Oh, I was going to say, so basically, even if, right now you're doing what I would consider to be everything right by having your compliance program in place that is mirroring all the guidance that's out there for you, CMS is saying they're not going to presume that that's enough. So they're not going to tie any presumption of reasonable diligence to that. So kind of in response to what you were saying before, Ernie, it might be something that providers may have to, fight about down the road. I mean, they may or may not have to, but it's just interesting that they declined to create this presumption.
Yeah, we have a comment by Val. It says this is similar to the UR conditions of participation. In that area, I have seen that as long as you have a reasonable plan and a way of reassessment of the plan on a specific period, you are fine. Yeah, I think we'd agree with that.
Yeah, definitely. And I think, I think a lot of hospitals follow the OIG guidance that's out there, which does have, just it's high level, speaks about auditing, things of that nature. I think, that it really ought to be enough, but we all have to wait and see what the final rule says on the mandatory compliance. But
right, so we're waiting for a final rule on that one, that the proposed rule about the elements of a program, because they haven't finalized that. And so in that way, it makes sense to me that they've declined to create the presumption of reasonable diligence right now because they don't have a final rule on what that involves yet.
True. That's true.
Okay, so, but it also just seems to me it's like, I don't know what to call it, double speak or whatever. It's just kind of, it's disingenuous. It's like, oh, well, we want you to do this, but if you do what we tell you to, that's not necessarily enough. How the heck are we supposed to know what to do? So it seems kind of, well, it seems rather CMS. It's kind of like, it's why I say David Copperfield is involved. It's an illusion. But okay, so other slide, next slide about proactive.
Okay. So basically, then they go on to say that if you don't have if you don't have proactive compliance at all, or if these activities are minimal, that could expose the provider to liability under the identified standard. So basically, if CMS were to come in and find an overpayment and they take a look at your proactive compliance activities and they feel that they were insufficient, they can then aim that, they could theoretically allege false claims act violations.
But I would say that you could certainly argue that, ultimately we're doing what you asked for under the identified standard, and you don't create. So it seems like no or minimal compliance activities. Well, if you're not doing anything, I could certainly see that. But I don't know how they would identify minimal if you were doing everything that was in. Of course, if you're doing less than what they suggested in that proposed rule, I suppose that leaves you open to a problem.
Yeah.
Anyway, so this gets back to what we were saying. This is probably a good time to go ask, your compliance department, do we have a plan? Is it written down? Does it comply with the OIG standards, at least at a minimum? And is there a plan to reassess it, apply it, and use it on a continuous basis? That's probably a big question that needs to be asked every once in a while. Because I think isn't that what you would be asking, Jessica, if you were involved in a case like this? First thing you can ask is, where's your plan?
That is the first thing I would ask, yes. Yeah.
Yeah. Okay. Now, here is another comment. This is why you have to know your operations and look at not just what the OIG is looking at, but also those areas that may be at risk. Yeah, once again, we go back to all these ideas of what's at risk. Now, we're going to talk a little bit more about that because I had asked Jessica some questions about that, like what kind of notice that you get implies that you need to go look. So we'll talk about that in a minute. Okay, reactive, and that goes right into what we're talking about now, the idea of a reactive. So you receive credible information concerning a potential overpayment.
Right. So you'll have to determine if the information you've received is credible. There's some discussion in the final rule about that you don't have to take every suggestion as credible information concerning a potential overpayment. That's a business decision for a facility to make a provider-supplier. But once you have determined that you have received credible information concerning a potential overpayment, then you have a duty to perform a reasonable inquiry to confirm or deny whether an overpayment exists. So in addition to just conducting proactive compliance activities as a matter of course, also from time to time if something comes up that brings an issue to your attention, then you do have a duty to investigate it. So this is when, we talk about the time frame, okay? So the 60 days is built in for all the non-cost report ones. So the reasonable inquiry must be performed with reasonable diligence. That's what the reg says. The final rule defines reasonable diligence as within 6 months of receipt of information related to a potential overpayment. And then if in the course of those 6 months you identify an overpayment, you then have 60 days to report and return it. So basically you have 8 months. So it's not really 60 days, it's really approximately 8 months. the thing that I would just like to highlight, just as an attorney, I find this to be interesting. The 6 months they discuss it a lot, but they discuss it in the preamble. It's in the Federal Register document. It is not part of the regulations. So if you try to go back and cite to the regulations that you have conducted your review with reasonable diligence, you're not going to find it in the reg. You're going to have to go back to the final rule.
Well, is that going to be in court? Is that going to be in front of a judge? Is that going to be acceptable? Is that going to be reasonable, or are they going to say, no, it's not the regulation?
Well, it's the only guidance that's out there. But I think it's, for non-attorneys, it's a little bit hidden, I think.
Okay, yeah.
Which is, I think it's problematic. They should just put it in the reg, but they didn't, so.
I would hope that's just an oversight on their part. But that's interesting. Okay, so from the time somebody comes to you and says, hey, we think there might be a problem here, you've got 6 months from that time to exercise what they call reasonable diligence, to perform a reasonable inquiry. In other words, go look and see whether or not that information is credible or is correct, that there was an overpayment. They can't just be anybody saying, hey, I think there's a problem.
Right.
They got to give you some kind of credible information. It's not just someone's opinion. Not just an opinion, I think we're doing this wrong.
Well, I mean, I don't think you should ignore an opinion either. I mean, if somebody comes to you with information, certainly I think there should be some sort of an investigation that makes it seem more significant than I mean it to be. I think any information should be considered, and what you decide to do with that information should be documented. If you determine that information you've received is not credible, that should be documented, and why you decided it's not credible should be documented. These are things the hospital just need to do it that way.
They need to put that in writing somewhere, yeah. Okay.
And if the inquiry is not performed and CMS determines an overpayment exists, then CMS may find that the provider has knowingly retained the overpayment because it failed to exercise reasonable diligence.
Okay.
Okay.
Well, it just behooves them to make sure that they're writing down everything about that. Okay, so more about the reactive. Possible.
The final rule cites several examples of situations that may create a duty to perform a reasonable inquiry. They don't necessarily create a duty to perform a reasonable inquiry. CMS discusses for a paragraph or so that these are just examples. They aren't mandates. But if, upon a review of billing records, a person determines certain services were incorrectly coded, resulting in increased reimbursement, that one's pretty straightforward. If a person receives notice of a patient's death, which is prior to the date of service on a submitted claim, I'm going to pause and talk about this for 1 second.
Okay.
Because what's interesting about this example, CMS is really into this right now. But what's interesting is that there's an edit in their system that the provider should not receive payment. I was involved in a handful of cases earlier this fall where providers actually lost their Medicare billing privileges because CMS found that they had submitted claims for patients that had died. And then, as part of our appeal and investigating the information, it was found that, these were patients where the HIC number was maybe 1 digit off, or they were a father and son with the same name. They were all, everything was totally explainable, and all of the claims had been corrected by the billing agency. When they were submitted, they got the return error, like, okay, you're not going to get paid for this. This patient has expired. And then the billing agency said, whoops, and submitted a corrected claim. Anyway, CMS used that as a basis for revoking this doctor's Medicare billing privileges. And, across my desk in October of last year, there were 3 cases. It was crazy. So
wow.
I'm going to pause for a second there, because what's interesting here is that you aren't going to receive an overpayment if this happens. That would just be a mistaken claim submitted. But
right, yeah.
In any event, they list that as an example. A third example is if a person obtains knowledge that services were rendered by an unlicensed or excluded individual. If you perform an internal audit and you find an overpayment, or if a governmental audit alleges an overpayment, or you experience an increase in revenue without explanation. So I want to take a second to talk about the governmental audit portion here, because I think that's something that everyone on the line here is going to have some experience with. So, who hasn't received an overpayment demand from any kind of Medicare contractor, be it a RAC or even a CERT contractor? CMS is taking the position that if a government audit finds that you've been overpaid, you are now on notice that there may be other overpayments out there. And you have a duty now to perform a reactive investigation as to whether there are additional overpayments and report and return any overpayments that you find. And we haven't gone to this part yet, but I'll just jump ahead for a second, that the reporting and returning of overpayments, the look-back period is 6 years for you. So even if you have the RACs that they're limited to a 3-year look-back period, but you're not similarly limited. So CMS is taking the position that, providers need to look back over the preceding 6 years. Now, this is shorter than the 10 years they originally proposed, but it's still really long. And they had to make a change in the regulations to even allow for it, because prior to publication of this year, claims really were only reopened, 4 years, unless there was evidence of fraud or similar fault, and that's, not the case here. So just need to be aware of that. The other thing that I would advise everybody on the line is when you are conducting your reactive investigation and performing your self-audits and trying to determine whether or not overpayments exist, I think that should be done under the attorney-client privilege. You need to really look closely at these claims, and, you don't have to take the RAC's advice that your claims have, resulted in overpayments to you. Everyone on the line knows that you can get a RAC denial overturned. So their findings are not gospel. That's why this just puts a duty onto you to take a look at your claims and see what you agree with. Which of do you think there are overpayments here? So I just think that analysis should be performed under the privilege. It should be a privileged analysis, and it should be fully documented if you find that, you either way. If you find that you don't have overpayments, if you find that you do, it's just a safer way to conduct these compliance audits. So.
Well, let's say so in other words, for RAC audits, we get, for complex audits, we get ADRs. So you get an ADR for a couple of different kinds of DRGs, a couple different DRGs. Now, does that basically trigger it at that point, or you have to wait? It doesn't trigger it until the RAC actually issues a denial and it sticks.
So the example here is when the audit alleges an overpayment. An ADR isn't an allegation of overpayment. It's just a request for records. So you're not on any type of notice until you receive
the denial letter. The denial letter.
Right.
Okay. But now the denial letter, what if you disagree with the denial letter and it goes, it's going, because then you're off to a, 18 months to 5-year process of you disagreeing with them.
If you disagree, you disagree. I mean, there's no obligation for you to. I mean, I truly believe that if you are maintaining the position that you have not been overpaid, there's really no reason for any refunds to take place at that time.
Right, and so then but is there also no reason? There's no duty then to go perform an inquiry because you disagree with the denial?
I think there is a duty to look at it. I think, what you find when you take a look at your sample is that you don't have a problem, then that should be documented.
Yeah, okay. Oh, and I think that's yeah. So you can create a sample. So now that's gonna come out of the process of trying to quantify an overpayment. Go look for it. I mean, if you're going to go look for it in more than one record, you're going to have to do a sample internal audit of some kind. Okay. And there's somebody was saying with the rack you can perform a peer-to-peer, and then somebody was asking that viewer to explain what they mean about peer-to-peer. Peer-to-peer is once you get the denial from the rack, you can request. You have to have a physician at your facility request to do a peer-to-peer review with the rack's physician. It has to be a physician requesting to do a peer-to-peer with a physician. If you don't use a physician to make the request, they won't send a physician to talk to them. So what you want is a physician-to-physician peer-to-peer review, but you have to directly request that from the rack soon after you get the denial. But if somebody else wants to explain it better in the comment box, please do. Anyway, let's go to the next slide because we start talking about what you do. I mean, if you're going to look into this and do an internal audit to look at an alleged overpayment, then let's talk about that, quantifying that overpayments.
They stop short of requiring, but I interpret the commentary to strongly suggest that providers engage in statistical extrapolation to project any overpayments they may have received. So a quote from the final rule comment for CMS states, after finding a single overpaid claim, we believe it's appropriate to inquire further to determine whether there are more overpayments on the same issue before reporting and returning. We understand a common way to conduct an audit is to use a probe sample, incorporate the probe sample into a larger full sample as the basis for determining an extrapolated overpayment amount in the probe. It is not appropriate for a provider or supplier to only return a subset of claims identified as overpayments and not extrapolate the full amount of the overpayment. So if you're put on notice that you may have an overpayment as part of your sample, they're saying, don't just give us that money, extrapolate that out. It's new and it's interesting, and that's what CMS is suggesting you do.
I think there's going to be a lot of argument over this because then extrapolation is not a simple process. And this is why I said that, from what I've heard, we've seen very few, considering the number of claims that are out there, we've seen very few extrapolation cases. I haven't heard about very many. I know there are some out there, but they don't happen that often.
ZPICs always.
ZPICs always do, yeah. Right.
ZPIC always does.
But they're about fraud, so.
They're a benefit integrity harm, but they're a lot of times not. In my practice, I have seen a ton of ZPIC audits against very good providers that are an outlier for whatever reason. They are the benefit integrity arm, but they always use statistical extrapolation.
Okay. The trouble with it is, and if you go look in the RAC statement of work, you can find information about what they expect on that, and there's more stuff out there. I don't have anything at the tip of my tongue about how to perform extrapolation, but it involves hiring a statistician and having that statistician be able to do an appropriate random sample in your full universe of that type of claim, and then there are all kinds of arguments about how that sample is obtained, and then also about how large your sample is. When I was in college, my professor in statistics said, you better have 1,000 at least in your sample or you're not going to have very good results. Well, I hardly ever see an extrapolation case in this industry of more than 100 or a couple hundred. So I don't understand how that can be anywhere considered near to be accurate, but they do. But anyway, it's always about, there's always arguments about it. So to me, what the problem is now they're requiring the provider to go do all those things and then bring it to CMS and be able to defend it to CMS. So CMS doesn't have to hire the statistician. And now they can pick apart your extrapolation, which, of course, they're only going to do that to make the number larger. So this is really, unfortunately, as Jessica said, it seems like they're not exactly requiring it, but they sure do word it like that's what they want to happen. They're saying here, maybe someone in somebody coming in, maybe someone in your financial department that can give you data about extrapolation. At any rate, it's a new thing. A lot of you are going to have to learn more about it than you ever wanted to know. But apparently they're not going to be happy now. Jessica, is this, so I think about this, I think, wait a minute. So last week I got a denial from Iraq, and I've gone through levels 1 and level 2, and it's still a denial. Does that mean now I need to go do what they're calling due diligence and go do extrapolation on a subset of my claims in order to find out some amount more than just the ones they denied?
Yeah. Non-audited claims, you mean? Yeah.
Yeah.
But I think you probably are anyway. So, there was a comment earlier about you shouldn't just look at what the OIG looks at. I agree with that. But if you look at the OIG guidance to hospitals for their compliance plan, that's what I was referring to. They paint with a very broad brush that your compliance, as part of your compliance plan, you should be looking at services that may be found to be medically unnecessary. If you have, services that may be upcoded, DRG, so they paint with a broad brush here. So as part of your compliance program, it would be my expectation that everybody on the line is conducting some sort of annual or other kind of internal audit. So this may already be happening. So, it sounds like it's certainly going to be new for a lot of other types of providers and suppliers, but it may already be happening in the hospital environment.
Okay. And then the bit that you and I have talked about before the show, that if you're going to do any of this, which you're going to have to do, you should do it under privilege. Mm-hmm. As much as possible. In other words, have your legal department involved so that it's not discoverable. Although if you do this kind of thing and then you turn it in and CMS questions your method of how you did it, I suppose that they can ask for even if it's done under privilege, or how does that work, Jessica?
Well, you have to turn in your statistical extrapolation data anyway. That's, I think, on my last slide. So you do have to, there is certain information that you're going to be required to disclose as part of the process. But I do think that it's important to just make sure your legal department is involved. I agree with the commenter that said that your compliance department should be involved. Like, that is also true. Compliance should be involved. Legal should be involved. Certainly the audit should be privileged. What I was talking to Ernie about before the call, for everyone else's benefit, is there recently was a case involving a consultant that consulted with a bunch of hundreds of hospitals nationwide on the appropriateness of pacemakers that were being implanted. And what happened is the consultant went to CMS and told on all these hospitals, and then there was this huge whistleblower case, and all the hospitals had to pay back a ton of money. And, I was reading about it, and the only thing I could think was, gosh, why wasn't that consultant retained under privilege? Like, why are they just running out and talking to CMS about everything? So I just think you have to tread lightly with these types of things.
Yeah. Okay. Yeah, I agree. It's and I certainly think it would be smart to do any of that kind of stuff under privilege, so you at least are protected. you don't have to expose any more than you have to.
Yeah, I think it has to be a team effort. I think, your clinicians are going to have to be involved to help with the medical necessity. Compliance is going to have to be involved. Legal certainly should be involved. I think, your entire hospital team should be boots on the ground here to participate. All boots on the ground should participate in reporting and returning if you decide you need to.
Yeah.
Okay, so this reconciliation, that's if you need to file a cost report. So then the reconciliation occurs at that time. So any overpayment would be returned at the same time that you file your cost report.
Okay. So let's talk about the look-back period.
Yeah, so we talked about this a little bit. So you have a 6-year look-back period measured from the date the person identifies the overpayment. So that would be your start date, I guess. It's interesting. So we have an effective date of this final rule of, March 14th of this year? So, but that's the time, there's an argument there about retroactive application of a law. Like, I don't know. I haven't thought through this with enough detail to speak intelligently on it right now, but I think there's an argument there that, up until February of 2016, it was 4 years. So there's an argument there, but the rule right now as it stands is there's a 6-year look-back period for your internal auditing.
Okay. So you want to just stay in touch with your lawyers about, is it, and say, here's someone saying it's a 6-year look-back period from the date of admission or discharge. It's from the date that the overpayment is identified, right?
Correct.
Right. So it has nothing to do with the date of admission. Well, wait a minute. Okay, no, I see what they're saying. When you're looking at claims in the 6-year look-back period, you're going to be using the date of admission or discharge. I would think it would be the date of determination, which is the date that CMS pays it. I would think that's the date they're looking at. I don't think you're going to be able to argue a whole lot about it, but yeah. And I don't think the date of
extrapolate look back, it probably wouldn't. That might be a little too in the weeds to even matter.
Yeah. I'd say just pick one.
Yeah.
Pick one. Any one of them is going to be pretty close to the deadline anyway, so we're within that deadline. Okay. How to report and return. This is our last. We're doing real well here.
So the proposed rule was going to mandate that everybody uses a form that says, okay, I did my due diligence and look at all these claims I found. And there were 13 data elements, and providers were saying, that's a lot to have to tell you about. So in the final rule in response to these comments, CMS did allow for all additional processes for returning overpayments to be used. So you can use the claims adjustment process, credit balance process, any self-reported refund process that your MAC may have in place. So you don't need to go down the road of using some form saying, okay, we did our due diligence and this is what we found. But you do need to explain your statistical sampling process. Yeah, Ernie's circling it now. So that's the big one.
Okay. So they're not really going to ask for all those data elements. But the statistical sampling stuff, they definitely want to see, which I think is burden enough. I just find it incredible that all of a sudden now, if you get a single claim denied by a RAC or a MAC, that suddenly triggers you have to do an internal audit for 6 years worth of data on that particular kind of claim. I mean, does that seem right?
If we're being, literal about it, yeah. This is just, it's such a tough thing. especially if we're talking about hospital appeals, if we're talking about, status appeals, right? So these are all, this has been a thorn in everyone's side since, 2006. So I think there's, as long as your reviews are ongoing, and again, talk to your compliance department, but I bet that they are. But as long as you are engaging reviews of the areas that may be areas of vulnerability for your facility, you're probably, operating appropriately for purposes of this rule. It's just, it is burdensome.
Just because like I said, it occurred to me. Wait a minute, if I get a status denial, does that mean I have to review all my inpatient claims for the last 6 years? I'm not sure what the heck that means.
Yeah, I think it just puts you on notice that there may be overpayments out there. So then, I think then you need to look into the issue. But what I'm saying is probably most facilities are. I feel like most facilities are watching these things as an ongoing basis. And just because CMS continues to kind of move the 8 ball.
Yeah.
Okay? It doesn't mean that you're billing inappropriately. It's just important that, these are issues that your compliance department is taking seriously, and these are things that are being watched.
Yeah, and then possibly there's one of the viewers saying if you receive one denial from the RAC, you need to drill down to see if this is an issue that needs an audit, or was the denial just from a one-time human error.
I agree.
Yeah, so I think that would be a good argument. If it was just an error, well, there's no need to go looking all over the place. But I don't know. It should be interesting to see what happens going forward. So anyway, well, this is how, if you want to chat with Jessica, here's her email, here's her phone number. She doesn't bite, so feel free to give her a call and chat about this if any part of this is unclear to you. I know she'd be happy to talk with you for a few minutes. And so, top takeaways from today's show: make sure you check your compliance plan, understand these definitions, get ready for what you may have to do with a 6-year look back, and also get ready for what you may have to do with extrapolations. These are not things that I think you are ordinarily prepared to do, but it looks like you're going to have to. You better start talking to your legal department and your lawyers and find out and let the board know this is not going away. I think it's going to be kind of a big deal going forward. So that's all the time we have for today. And look, we'll be back live next Friday, April 22nd, with a special presentation by Dr. Eddie Hugh, which will be all about what he's learning about sepsis and those new definitions. Eddie's been writing things on rack relief lately, and I finally got to be able to get him on a show. So mark your calendar now and bring your questions for Dr. Hugh. Also watch for my announcements about Sharon's webinar next week about the ambulatory CDI. That's a free webinar. It should be available up by Monday or Tuesday. And coming up, we've got Managed Care Anguish Part 2 will be on May 20th. And that's the only one we got planned so far in May, but just keep watching. Thanks very much to everyone for participating today. Especially thanks to you, Jessica, coming in and sharing your knowledge and experience with us all on this difficult subject. And also thanks to everyone who participated in the chat box today. Of course, we also owe thanks to our sponsors and partners, the Health Law Partners, EdLinks Cost Containment, MAS Coding Solutions, Recovery Analytics, and the CCMA. It's their contributions that make these broadcasts possible and free for you every week. So watch for my emails about the April 22nd show, and please share the links to our show with your colleagues and friends. And the last thing I want to share with you is something that I always tell my children. Well, this is pretty close to what I tell them every week. Don't grow up. It's a trap. Actually, what I tell them is don't grow up. Don't grow old. You'll be disappointed. Anyway, that's all I got this week. We'll see you next time when it's finally Friday. Have a great weekend, and bye-bye.